Afternoon or evening. Okay. Wherever you are, good morning, afternoon, or evening. My name is Dr. Abbas, and I'm a consultant physician, endocrinologist, and diabetologist based in Dar es Salaam, Tanzania. I'm a president of D-Foot International and a regional chair of English-speaking region from Africa, Sub-Saharan Africa. I'm honored to have an opportunity to chair this session. I should also like to welcome Professor Maimuna Mgaya, who's going to chair with me as a co-chair, Professor of Medicine at Cheikh Anta Diop University of Dakar. She is currently head of the Internal Medicine Unit and a director of National Diabetes Center in Dakar, Senegal. She is a regional representative of D-Foot International for French-speaking countries in Africa. And we are always honored to have her here. It's so nice. She's always supporting us. So you all are welcome. We are privileged to have honor to start this first session of flagship program of D-Foot Diabetes Foot Awareness Week, starting from Sub-Saharan Africa, followed by other 6 regions, which will run daily over the course of coming week. On 12th November, Sunday, we will have a global meet where all the regions will come under one roof. So you are all welcome. Today, we have 5 speakers from Sub-Saharan Africa, and we all welcome of them. We are going to present a short video of 3 minutes introduction on D-Foot International and a message. Ali, can you show that? It is an honor and privilege to address you today as President of D-Foot International. I speak not only to the diverse and vibrant individuals present here today, but also to hearts and minds of millions worldwide, united by a common cause to combat diabetes-related food complications. D-Foot International is an organization consists of people working in the field of diabetes-related food complications. These people are spread across 7 regions in the world: Sub-Saharan Africa, South and Central America, Middle East and North Africa, North America and Caribbean, Europe, Southeast Asia, and Western Pacific, all dedicated to providing preventive food care for people with diabetes through awareness, education, and professional guidance. The looming global diabetes epidemic is a step reality, projected to rise with the highest burden in low, middle-income countries. As diabetes rates surge, so does the incidence of diabetes-related complications, including food-related complications, which is our focus of action here at D-Foot International. Our mission of D-Foot International is resolved and clear, ending avoidable low-living amputation due to diabetes worldwide. It is not just a vision, but a mandate, a call to action, demanding our utmost attention and urgency. We should all unify our goal and aim for a 50% reduction in limb amputation rates by 2026. In this mighty ambition, education and the empowerment of healthcare profession are our only weapons of choice. As I often say and will continue to say, education is only powerful tool we have. Education is power, especially in the low middle income countries, where it is free and immensely effective when properly implemented. It is noble pursuit. We at D-Foot International are proud to see the happenings of Diabetic Awareness Week campaign. This campaign, we find each one of you as a faithful ally in this great endeavor. The success of D-Foot International goals depends on your patience and efforts for educating communities and obviously raising awareness. Diabetes Awareness Week campaign is one of the flagship program of D-Foot International. As every year, this year we'll have programs in all the regions starting from 7 to 14 November. We have one day allocated for global meet where all the regions come together on one platform. Today, I invite every one of you to picture a world where every healthcare professional is prepared to offer knowledge and skills to provide specialized food care. Imagine a nation where stigma attached to preventable amputation is eliminated and a gap between affordable and accessible diabetes food treatment is permanently addressed. Coming closer to the end of my short introduction, D-Food International extends a hand of collaboration to every one of you. Let us work together to promote care of diabetes-related food complications and their management, making it financially feasible and increase awareness about it. Lastly, I would like to personally thank everyone present here today for being part of this noble cause. We look forward to the impact we can create together. Thank you so much. Thank you.
Okay, thank you very much. So we move forward now to the first speaker. Felicia will join us later on, so I've requested Dr. Hardeep Gill to take as a first speaker. Dr. Hardeep Gill is a consultant vascular and endovascular surgeon. He graduated from University of Nairobi in 2003. He proceeded to his internship in a provisional general hospital and community service at District Hospital in 2005 and 2006. In 2007, he proceeded to South Africa to become a general surgeon and at the University of Cape Town, where he graduated in 2011. He also got a gold medal in fellowship exam in COSECA in December 2011. Thereafter, he proceeded with his subspecialty in vascular surgery. Currently, he's working in a private practice in Nairobi at two hospitals, MP Shah Hospital and Aga Khan University Hospital. I really welcome him to give a talk at the peripheral arterial disease in African population, how to manage in Africa, and what is the way forward. Welcome, Dr. Gill.
Thank you very much, Dr. Abbas. Thank you for inviting me for this symposium. It is amazing. Let me just start by sharing the screen. It says host disabled participants screen sharing.
So, Ali, can you help that?
Again.
Yeah, he's done. Okay, try
it.
that.
Okay, let me try that. All right. Is that seen?
Yeah, we can see it.
Okay, thank you very much. And welcome everybody to this symposium. And thank you very much, Dr. Abbas, for the kind introduction. So my topic today is peripheral arterial disease in the African population, how to manage in Africa and the way forward. So to start off with the epidemiology and etiology. So peripheral arterial disease is defined as an established occlusive disease involving the circulation of the extremities. And PAD is one of the components of cardiovascular disease affecting mainly the lower limbs. More than 90% of the pathology in PAD is due to atherosclerosis. Indeed, in Western literature, atherosclerotic peripheral arterial disease is synonymous with just peripheral arterial disease. So a resting ankle brachial index, an ABI of less than 0.9, is caused by a hemodynamically significant arterial stenosis. And what we mean by that is a more than 70% stenosis, and is universally accepted as the hemodynamic definition of peripheral arterial disease. As you can see in this diagram, that's a normal vessel, and that's plaque that has built up and caused narrowing in this vessel. So it is hemodynamically significant if it is more than 70%. So the community prevalence of atherosclerotic PAD averages about 10% by the age of 65 years in most studies. The prevalence is age-related. It's low in patients between the age of 50 to 60, about 2.5 to 5%, and increases with advancing age. The prevalence is more than 20% for patients older than 70 years. Approximately 10 to 50% of claudicants do not consult their doctor. More than 50% of patients with PAD have no symptoms or have atypical claudication. So smoking correlated with a higher prevalence of PAD in southern sub-Saharan Africa compared with other regions in Africa. A review of PAD in sub-Saharan Africa reported that the prevalence of PAD may be equal to or higher than in developed countries, exceeding 50% in some high-risk populations. The global prevalence of PAD has increased by 24% in a span of 10 years, from about 160 million to 202 million people. The number of individuals living with peripheral arterial disease is increasing as a result of total population increase, global aging, increased incidence of diabetes mellitus, and smoking in developing countries. So a worrying trend is the increasing prevalence of PAD in sub-Saharan Africa, especially southern sub-Saharan Africa. And previously, the only available data from a general African population were reported by the Southern African Stroke Prevention Initiative study. In this study, PAD was reported in about 25% of patients over the age of 60 years. And the prevalence in Bangui is about 15% and Brazzaville about 32.4%. The higher prevalence in Brazzaville has been attributed to urbanization and the adoption of a more Western lifestyle. So let's just have an overview of some of the studies that have been done. And one of them is from Nairobi, Kenya, by our colleague and Nikita Mehta. She's a cardiovascular surgeon. So she looked at the prevalence, progression, and associated risk factors of asymptomatic peripheral arterial disease. And she saw that the prevalence of asymptomatic PAD in patients with at least one associated cardiovascular risk factor is 36%. There is an almost twofold risk of progression of asymptomatic PAD in patients with two or more cardiovascular risk factors. Now, a study done in Nigeria, all these studies that I'm mentioning have looked at the prevalence based on an ABI that was done. So this study found that the prevalence is about 3 to 24% of adults aged 50 years or older, and about 40 to 50% among diabetic individuals. Study done in Ghana also looked at about 200 patients, and the study showed a prevalence of PAD of between 17 to 18%. A study done in Uganda showed that the prevalence of PAD in about 229 diabetic patients was about 24%. So we can see at least 25 to 40% prevalence we are seeing. Another study done in Uganda as well showed a 43% reported claudication by the Edinburgh Claudication Questionnaire. So basically a hospital-based study looking at diabetics over the age of 50, and all these investigators have used an ABI to calculate the presence of peripheral arterial disease. Another study done in Angola also showed a prevalence of about 40%. Study done in South Africa involving about 542 subjects showed a prevalence of about 29.3%. And all these patients were above the age of 80, and females were more than diabetic and obese and hypertensive than men. Another study done in Nigeria showed a prevalence of about 28.7%. Another one done in Nigeria, most of these studies have been done in Nigeria, show that the prevalence is 25.7% using clinical palpation and about 55% using an ABI of less than 0.9. And that's probably the highest that we have seen. And in type 2 diabetics, they have also found a prevalence of 62%, but this is a small study, it's only including 74 patients. Another study done in Benin showed a prevalence of 35.5%. And a study done in South Africa, high prevalence in rural Black South Africans. So this is a study that was done in 542 patients. And in this study as well, prevalence is 29.29%. So There's another one done in Malawi that looked at the prevalence and risk factors of lower extremity disease in high-risk groups in Malawi. So they found that 1 in 4 individuals with 2 or more cardiovascular disease risk factors have evidence of lower extremity disease, and 2.4% already had active signs of limb-threatening ulceration or previous amputations. Now, if we look at the pattern and distribution of atherosclerotic PAD, so based on the pattern and distribution of the occlusive disease that define the pulse status, PAD can be categorized into suprainguinal, which is the aortoiliac disease, or infrainguinal, which is the femoropopliteal disease, and below the knee called the tibioperoneal disease. The anatomic profile of occlusive disease varies according to risk factors. For example, tibioperoneal disease is more common in diabetic patients and patients who've got end-stage renal disease, whereas aortoiliac disease and femoropopliteal disease is more common in smokers. So looking at the clinical spectrum, a patient presenting with peripheral arterial disease could be asymptomatic or could be symptomatic or complicated. Symptomatic patients could be having intermittent claudication or erectile dysfunction. Complicated patients could be having acute limb ischemia, chronic limb-threatening ischemia, isolated risk ischemic rest pain, or with tissue loss in the form of ulcers or gangrene. So in intermittent claudication, patient classically presents with exertional calf symptoms, which are relieved by standing for 3 to 5 minutes. So they walk a certain distance and they feel that their calf or the thigh muscles or the buttock muscles have started cramping. This pain is usually reproducible and the distance is almost the same. So patients with aortoiliac disease may present with associated thigh or buttock claudications. Patient with Leriche syndrome classically present with a triad of buttock claudication, erectile dysfunction, and absent femoral pulses. And there are several differential diagnoses of intermittent claudication. One can have spinal stenosis. One can have venous claudication as a result of outflow obstruction, like in DVT. And the other causes of leg pain, like osteoarthritis, fibromyalgia. All of this can present with features of that mimic intermittent claudication. And the clinical severity for peripheral arterial disease can be categorized using the Fontaine or the Rutherford grading systems. Ischemic rest pain is severe ischemic neuropathic pain, which is experienced when lying in a recumbent position. So when a patient lies down flat, they've got severe pain. And to relieve that pain, they prefer to hang their feet off the bed. And that helps, whereby gravity helps in aiding the perfusion of the foot. Now, tissue loss may present as ischemic necrosis, focal skin necrosis, or gangrene of the digits and or forefoot, or ischemic ulcerations. So foot ulcer is considered to be due to PAD unless proven otherwise. So there can be other causes like venous ulcers, neuropathic ulcers, but usually if you have a foot ulcer, you have to make sure that you have excluded peripheral arterial disease. Palpation of foot pulses is essential. Doppler pressures and ABI should be evaluated in the absence of foot pulses. Due to calcification of arteries in diabetic patients, the ankle pressures may be falsely elevated, giving rise to falsely elevated ankle brachial indexes. So in diabetic patients who've got a foot ulcer, gangrene, and ABI of more than 0.6 is not reliable. These patients need to be investigated further with toe pressure measurements because the toe arteries do not get calcified. Then transcutaneous oxygen pressures, if it's available. So this is how basically tissue loss is presenting. Previous amputations done for gangrene, dry gangrene of one toe, gangrene of a couple of toes, and sometimes basically complete fixed skin staining presenting as an acute limb ischemia. So in acute limb ischemia, these patients present with acute circulation disorder involving the lower extremities. Usually the symptoms are present for less than 2 weeks. It's because of a sudden occlusion of the arterial supply to the leg. And patients present with pain, pulselessness, paresthesia, pallor, poikilothermia, which the reduced temperature of the foot is very cold, or paralysis. So comprehensive history, clinical appraisal, and Doppler interrogation is mandatory at baseline patient evaluation. Now, chronic limb ischemia or limb-threatening ischemia, what we call critical limb ischemia, these patients already have established PAD. So they have absent foot pulses and their ABI is less than 0.9. They present with ischemic rest pain for more than 2 weeks and associated with one or more abnormal hemodynamic parameters. So to get critical limb ischemia, the ankle brachial index is usually less than 0.4. The highest ankle pressure is less than 50 and the highest toe pressure is less than 30. Then TCPO2s, which is transcutaneous partial oxygen pressure measurement, is less than 30 millimeters of mercury. Now, this is an advanced tool and it's not readily available. And you can even look at the pulse volume recordings to see how the flow of blood is. There's tissue loss, gangrene, and non-healing ulcers for more than 2 weeks. So what's the fate of the leg in patients who've got peripheral arterial disease? The prognosis is generally benign in asymptomatic or symptomatic PAD, and only a quarter of the patients, so 25% of patients with intermittent claudication will significantly deteriorate, and only a very small percentage will progress to critical limb ischemia requiring intervention. Major amputations are quite rare in patients who've got intermittent claudication, so like about 3 to 5%. However, patients who've got critical limb ischemia, their chances of having amputations are quite high. So a changing ABI is the best predictor of progression of disease. Although those with a low ankle pressure are at risk of progression to severe ischemia or limb loss per annum. So most patients with critical limb ischemia receive some form of revascularization. So what's the fate of the leg? So if you see, if 50% of patients have been revascularized as a primary treatment modality and 25% receiving only medical treatment and 25% receiving only a primary amputation, a year down the line, 25% are dead. In 25%, the critical limb ischemia is resolved, but amputated, and 20% will have continuing critical limb ischemia. So what's the fate of the patient in critical limb ischemia? So they have an annual incidence of non-fatal MIs of about 2 to 3%. The 5, 10, and 15-year morbidity and mortality rates are 30%, 50%, and 70%. So patients who've got peripheral arterial disease, they have polyvascular disease, they have coronary artery disease. So myocardial infarction is the biggest cause of death in these patients. Now, ABI is a good predictor of mortality. There's a linear relationship between ABI and fatal and non-fatal and cardiovascular events. Each decrease in ABI of 0.1 is associated with a 10% increase in a relative risk of major vascular event. The lower the ABI, the higher the 5-year risk of cardiovascular events in a diabetic patient. So in history, you should look for detailed assessment of any pain or inappropriate lack of pain. Some diabetic patients with sensory neuropathy may not feel pain from severe foot ischemia. And look for intermittent claudication, look for ischemic rest pain. Then other things to look for are the duration of diabetes and the degree of diabetic control, looking at the HbA1c levels, history of smoking, family history of vascular disease, hyperlipidemia, and assess for other symptoms of vascular disease or a history of TIAs, stroke, angina, or myocardial infarction, as these will indicate the presence of established vascular disease. So in clinical examination, the inspection should be meticulous, remove all clothing, socks, and the heels and interdigital cleft should be particularly examined for evidence of necrosis, ulceration, pus. The color of the foot should be noted. So ischemic feet, so the palm of it, the plantar aspect of an ischemic foot is basically white. There is hardly any blood that's flowing down. And if it's like very red or a sunset foot, that indicates severe ischemia. So there's a test called the Burgess test, whereby you elevate the feet, and if the plantar aspect becomes pale, then there's reduced perfusion on that area. And then you let the foot hang off the bed. And if it becomes very red, that's rubor or dependency, then that's a positive Burgess sign. It indicates presence of autonomic neuropathy, and it indicates the severity of the peripheral arterial disease. So on examination, you're going to look at all the pulses. The foot should be examined well. Often foot pulses are absent. And what you have to see is patients, you'll have to examine their femoral pulses, popliteal pulses, and foot pulses. So there are 3 foot pulses that you have. That's the dorsalis pedis, osteotibial, and peroneal pulses. So if there's a weak femoral pulse or an absent femoral pulse, then the patient has an aortoiliac disease. If there's a strong femoral but a weak popliteal pulse, and the patient has femoral popliteal disease. If the patient has a popliteal pulse but no foot pulses, that patient has tibioperoneal disease. And that's how you examine the foot pulses. Thereafter, do an ankle brachial index, and you take the pressure, the highest pressure in the foot, divided by the highest pressure of either arm. So a normal ABI is more than 0.9 to 1.1. If you have an ABI of less than 0.9, then you have peripheral arterial disease. Between 0.4 and 0.9, you're in the intermittent claudication range, and less than 0.4, you have critical limb ischemia presenting with rest pain or gangrene. So that's normal ABI, 0.9 to some studies take up to 1.3, but 1.1 is okay. So if it's more than 1.3, these are poorly compressible vessels. They've got calcification, so you cannot compress them and get a pressure. 0.6 to 0.9 indicates mild arterial obstruction, 0.4 to 0.6, moderate obstruction, and less than 0.4, you've got severe obstruction. That is followed by a duplex ultrasound arterial mapping, whereby the entire artery, the femoral artery, popliteal, and the tibial arteries are mapped. We are looking for areas of stenosis. We're looking for the waveform over there. We're looking for aliasing, like this colorful area over there, which suggests stenosis. We're looking at the velocity and certain criteria to assess, is this a stenosis? What's the degree of stenosis? Is it high grade? Is it moderate? Is it an occlusion? What's the length of it? Now that is followed by a CT angiogram, and the CT angiogram is actually a roadmap. It gives us a roadmap of the vascular tree. You can see the entire tree, how it is. You can see areas of occlusion, areas of calcifications, areas of stenosis, to help better plan your treatment, whether it's going to be an endovascular treatment or open surgical treatment. So invasive angiography, it's done with the intention to treat. So you just don't do angiography, invasive angiography just like that. It's usually done with the intention to treat, because you have access to a CT angiogram before. So you have an idea of what type of treatment you will be performing should you go for invasive angiography. And it's done in a cath lab. That's how a cath lab looks like. It's got the table and the image intensifier, or the C-arm. You make a puncture on the femoral artery. All these procedures are done under local anesthesia and very minimal mild sedation, and that's the needle for puncturing. Inject dye, take images at different levels, see areas of stenosis or occlusions. So once you have identified what you're going to do, so let's look at the treatment modalities that we have. So angioplasty and stenting is a very important treatment that we do. So this is a diseased blood vessel that has got plaque built up, and you have to cross this lesion with a wire and dilate it with a balloon, plus or minus, leave a stent so that it can remain open for a much longer time. So let's look at the different armamentariums that we have. So we've got plain angioplasty balloons. These are uncoated balloons. They've got no drug on it. This is how an angioplasty balloon looks like when it's inflated. These are the different sizes. diameters and lengths that we have. This is an example of a balloon called an Admiral Extreme by the company Medtronic. So this is one of the commonest balloons that we use. Then there are other balloons for the vessels that are below the knee, the tibial angioplasty balloons. These are 2 to 3 millimeter balloons, much longer balloons that we use for angioplasty below the knee. Then there are drug-coated balloons, and the drug that's coated on them is paclitaxel. Now, paclitaxel helps in reducing stenosis. It helps in reducing the smooth muscle migration and proliferation in the tunica media that results in stenosis. So you see this is a lesion that's treated with a drug coating balloon, and 1 year down the line, it is still open with very minimal areas of stenosis. Then there are balloon expandable stents. An example is VisiPro. And so they've got a stent that's mounted on the balloon, and it's used basically for areas that are like you need very high precision where exactly to mount them, like in the common iliac arteries or areas where there are bifurcations. Covered stents are also used. They are much more expensive. They're mainly used usually if there's bleeding. They can still be used where there's atherosclerotic plaque. The advantage is that plaque will not really have a chance of growing through this mesh, which in a plain stent, it would be going through. Self-expanding bare metal stents are like this. They've got different types of deployment mechanisms. Like this is a wheel deployment mechanism. This is how the stent looks like. And that's the entire delivery system. This is how it looks like when the stent opens up as you roll the wheel. Drug-eluting stents, they have got paclitaxel or sirolimus coated on them. It helps to keep the vessel open for much longer. As you can see in this angiogram over here, this is treated by a drug-eluting stent, and further down the line, this is open for quite some time. We even have a drill. It's called a Rotarex machine. So it's a directional atherectomy device. You get through the vessel, cross it with a wire, and it's got a drill that excises the plaque. This is just an example. This artery, that's the profunda artery, the superficial femoral artery is supposed to be running here. It's all occluded. And this is after the plaque has been removed. And after the plaque is removed, as much of plaque burden that you can remove. After that, angioplasty, and you've got a fantastic result post atherectomy. Another example, this is how the plaque looks like that's been removed. So tibial angioplasty to treat a foot ulcer. So this is one of the examples, a patient presented with the gangrene of all the toes, transmetatarsal amputation done. An initial angiogram shows a very diseased superficial femoral artery, areas of occlusions, and lesion crossed with a wire, and balloon angioplasty started. You can see wherever there's a waist over there, those are areas of high-grade stenosis, which finally open up completely. This is down the popliteal artery, down the anterior tibial artery, all the way down into the foot. This is an iliac artery that has been angioplasted and stented as well. So you can see the pre-result and immediately post-op result. Similar lesion, multiple areas of so high-grade stenosis presenting with gangrene, angioplasted, and that's the immediate result after that. So how do you assess success? So success is assessed in different ways. So primary patency, assisted primary patency, secondary patency, and target lesion revascularization. So in primary patency, we are looking at absence or occlusion or significant restenosis in the treated segment. Assisted primary is when you do another procedure to prevent recurrent stenosis. Secondary patency is when you try to open up a vessel once it is occluded, and target lesion revascularization is re-intervention in an area that you had already intervened in the index procedure. So these are some of the things that we look at. What's the determinant of outcome? So we look at the length of the lesion. And if it's short, it's better. If it's long, the outcomes are a bit difficult. Is it a stenosis? Is it an occlusion? Is it focal stenosis? Are there multiple stenosis? What's the pattern of vascular disease? Is it a single level disease? Is it multi-level disease? what's the runoff? Is it normal? Is it the normal runoff is 3 vessel runoff, or is it poor runoff, less than 3, maybe 1 vessel runoff? Gender also plays a role. Females have smaller vessels. That's the reason. What was the indication? Was it claudication? Was it critical limb ischemia? Did you have any problems during the procedure? Was there residual stenosis? Was there dissection? So this is all that determines the outcome. So of a lesion. So this is another area over there that's been angioplasty. It's a popliteal artery, multiple angioplasties done, and then finally a good runoff. So technical success depends on flow to the pedal arch. You can do whatever you want, but if you don't have flow to this pedal arch, then you're not going to save that foot. Now, treatment outcomes. If you look at angioplasty of the femoral popliteal segment, good outcomes. Initial technical success, close to 100%. Limb salvage, 70 to 80%. And 3-year patency, 60% for claudications and claudicants, and about 40% for patients with critical limb ischemia. Now, angioplasty and stenting, if you look at it, the pink one over here, that's angioplasty, and the darker one there is stenting. In terms of restenosis, stenting will give you a much less rate of restenosis. If you look at that's on ultrasound and duplex. So stenting will definitely cause the vessel to restenose at a much lesser rate. Now, if you compare angioplasty and stenting in claudicants or in patients with critical limb ischemia, the one that's in red is the stent, and the pink one over here, pink diamond, that's angioplasty. For claudicants, not much of a difference. For critical limb ischemia, stenting is definitely much far superior to patients who will just undergo plain balloon angioplasties. Now, drug-coated balloons, that's coated with paclitaxel versus plain balloons, the advantage is definitely a lot more in drug-coated balloons. Areas you've got less stenosis in drug-coated balloons. Primary patency is a lot higher. Clinically driven target lesion revascularization, TLR, means redoing an angioplasty is much less with a drug-eluting balloon compared to an angioplasty balloon. So a drug-eluting balloon or a drug-coated balloon achieves substantially better primary patency at 1 year compared with angioplasty. The stenosis rate in drug-eluting balloons is much less. Late lumen loss in drug-eluting balloons is much less. If you look at target lesion revascularization, much better with drug-coated balloons in different studies. And this is at 1 year. This A is at 1 year, B is at 2 years. Still much better. All that's favoring drug-eluting balloons. Amputations, major amputations after 12 months between the two groups, not much of a difference. You can see that this has crossed, is actually touching the straight line over there. So there's no difference between amputations, whether you use drug-eluting balloons or plain balloons. So drug-eluting stents versus drug-eluting balloons. For the first year, not much of a difference. Thereafter, there's some difference between drug-eluting stents being better than drug-eluting balloons. So a special consideration. So at the area of the groin where the common femoral artery is, that area cannot be angioplasted because you cannot put a stent over there. And it actually is best treated by an endarterectomy where you make a surgical incision, remove the plaque, and you can see the primary patency for endarterectomies versus angioplasties is far more superior in the 90s. So angioplasty versus bypass, it all depends. It depends on the life expectancy of the patient. If the life expectancy is less than 2 years, go for balloon angioplasty. If the life expectancy is more than 2 years, go for bypass surgery. And there's no difference in amputation-free survival at 2 years. And that's in this trial that was done some time ago called the Basel trial. Infrapopliteal angioplasty, good outcomes as well, 60 to 80%. Complications will be technical failures, flow-limiting dissections, residual stenosis, acute thrombosis, distal embolization of particles. So why would you have failure after 30 days? And that is intimal hypoplasia because of smooth muscle migrating there, or progressive atherosclerosis. Follow-up scans need to be done. Long-term management has to be done as well. Surgical revascularization bypasses are done when endovascular is not possible. This is an aortobiofemoral bypass graft. This is a femoral-popliteal bypass graft. You can even get blood down to the femoral arteries from the axillary artery. That's an axillobiofem graft, or one femoral artery to the other. That's a fem-fem crossover. So complication due to lack of treatment, of course, is amputations at different levels. Medical management would be antiplatelets with aspirin or clopidogrel or a combination, statins like atorvastatin, rosuvastatin, and other combinations, smoking cessation, good glycemic control with an HbA1c of less than 7, good BP control. In diabetics, they say less than 130/80, supervised exercise programs. So let's just look at this. This was a review article done in Nigeria. So barriers to peripheral arterial disease interventions in sub-Saharan Africa. Okay, so basically the summary of all of this is that PAD in Africa is often unrecognized, underdiagnosed, and undertreated. PAD interventional barriers in Africa include lack of interventional cardiologists or radiologists trained in peripheral interventions, lack of access to equipment needed, late presentation, basically what you're seeing in the pictures here, late presentation, inadequate education and training of healthcare providers to test for the condition, low level of public awareness to advocate for receiving testing, lack of funding for interventional radiology, cardiology, vascular surgical procedures. So the concern in Africa is that limb salvaging vascular treatments are not implemented in most African countries, and that major amputation is the standard of care for critical limb tissue ischemia. Of even greater concern is a relative lack of implementation of evidence-based medical treatments in people living with PAD in most African countries. The economic impact of such health practice deficiencies is not defined currently. This needs to be better defined to drive a more comprehensive PAD program aimed not only at patient identification, education, and treatment, but also an upgrading desperately needed health resources in these African countries. So a more concerted effort should be made to identify patients with PAD earlier so that disease-altering, evidence-based medical therapies can be instituted to reduce the incidence of cardiovascular death, MIs, and strokes. This may take the form of more aggressive and sustained PAD awareness campaigns, physician education, community workshops, etc. This is what has come out from that paper. So food for thought. Let me tell you something. It costs only $20 to examine a foot. It costs about $2,000 to do an amputation. But to do limb salvage, it costs about $20,000. So please examine the foot for pulses. And with that little, thank you very much for your attention.
Thank you very much, Dr. Jill. It was very comprehensive and very nice to the point.
Thank you.
We'll have question answers in the end. You have 6 questions I can see, and I've already written them.
Okay.
So you wait, and once end of the session, we'll then discuss the important questions.
Yes.
Before I proceed, I would like to welcome Professor Shakawi, who has joined us. He's one of the regional advisory from MENA region. So welcome, Professor Shakawi. Professor Felicia has also joined us. So I'm not sure whether she's ready or should we go to another speaker.
Good evening. I'm ready.
Okay.
If you are ready for me, I'm ready.
Okay, so then maybe I introduce you and then you can proceed, and then we'll hand over to Memuna later on. Okay, so Professor Felicia is a professor of medicine, endocrinology, and diabetology. She is a member of West African College of Physicians, fellow of National Postgraduate Medical College of Nigeria, fellow of Endocrine Metabolism of Nigeria, fellow of American College Endocrinology, fellow of Royal College of Physicians, London. She was a dean of the Faculty of Clinical Science, University of Abuja, and honorary consultant physician at the University of Abuja Teaching Hospital. Professor Felicia is a member of Governing Board of University of Abuja Teaching Hospital. Currently, she is a president of Diabetic Foot Nigeria Initiative, board member of Pan-African Diabetic Food Study Group, and she is a representative of DFood International from Nigeria. She is going to talk on very important initiative which we have started in Africa, and we are very proud of it. Why we need a master course in diabetes in Africa, initiative by University of Abuja. Welcome, Professor Felicia. Welcome.
Thank you very much, Dr. Abbas. Can I share my slide?
Yeah, you can. I think you have an access.
Okay. You can see my slide?
Yes, we can see it.
Okay.
You can start.
Okay. Thank you very much. My talk is on why we need master course in diabetes in Africa. Excuse me, an initiative by the University of Abuja in Nigeria. Diabetes is one of the fastest growing global health emergencies of the 21st century. In sub-Saharan Africa, diabetes is on the increase, leading to a significant negative impact on individuals, daily life, families, and communities. This imposes heavy burden on public health and socioeconomic development of any nation. We are very familiar with these figures, so I'm not going to waste time. But if we look at Africa, 2021, we had 24 million people with diabetes, but by 2045, we're expecting 55 million. That's mind-boggling because in using Nigeria as an example, and I know that's the situation in some of the sub-Saharan African countries, we run an out-of-pocket system. And if we have this, we know diabetes is an expensive disease. And therefore, if we have this kind of number, we are going to run into serious trouble. We're also quite familiar with this, that 1 in 10 people live with diabetes, and very importantly, 1 in 2 people who have diabetes don't know. And we know that we have more than 50% of people with diabetes in sub-Saharan Africa that are not yet diagnosed. And by 2021, 6.7 million people died from diabetes-related complications. Complications of diabetes. Diabetes can be a silent disease until the onset of complications. The complications of diabetes contribute significantly to the increased morbidity and early mortality. Adults with diabetes have a 2 to 3-fold increased risk of heart attack and stroke. The prevalence of end-stage renal disease attributable to diabetes is up to 10 times higher in people with diabetes than those without diabetes. The lifetime risk of a person with diabetes developing DM foot ulcer is as high as 25%, and about 20% of patients with foot ulcer will subsequently require amputation. We have just listened to a presentation on peripheral arterial disease. Mortality related to diabetes is increasing. 6.7 million adults were estimated to have died as a result of diabetes-related complication in 2021. Now, diabetes education. The background to diabetes education. Healthcare professionals are accountable to people with diabetes to provide current and necessary knowledge and skills needed for them to manage their diabetes and achieve positive health outcomes. So we have an obligation towards these patients. We have a responsibility towards them. And many times what happens in Nigeria and in other African countries, our patients feel let down. We disappoint our patients. By the time they are coming with a gangrene and they have been seeing a healthcare provider, or they've been going to some health facility and yet come down with gangrene, for example, or come down with stroke, come down with, a heart attack, we have failed them. In order to effectively teach others, health professionals must have sound knowledge, skills, and competence at an advanced level. Therefore, diabetes education is a specialty. Healthcare professionals, within their role and scope of practice, provide diabetes education, care, and management. It is important that they give consistent, evidence-based messages. In Nigeria, diabetes care is being carried out at the primary, secondary, and tertiary levels of care. In many centers, either there is no diabetes education at all, or and its complications, or it is provided too late. Healthcare professionals are hardly prepared in diabetes education and management. Administrators and providers have to be made to recognize the integral part diabetes education plays in the management of diabetes. That specific education is required to enable health professionals to be effective diabetes educators. What's the reason, for diabetes? Why are we so concerned about education in diabetes care? People with diabetes need a basic level of information to care for the disease and to prevent complications. They need knowledge and skill development to understand and manage the condition. They need the confidence to use that training for better self-care and greater compliance. Therefore, education influences the quality of life of a person and can actually make a difference between life and death. I had a patient came to, when I was in Lagos University Teaching Hospital, a male who had had diabetes for 12 years with neuropathy at some stage, bought a new shoe. He never had diabetes foot care education within these 12 years. And he bought a new shoe and wore it the whole day. And it was tight. Of course, he never felt any pain. And at the end of the day, when he removed the shoes, he saw bruises and, not properly managed. At the end of the day, he came with gangrene and sepsis, and he died from that. So you can see lack of education made him to die from simply going to buy a new shoe. Tell me, and I will forget. Teach me, and I will remember. When you involve me, then I learn. This is from Benjamin Franklin. Masters in Diabetes Education, MSc DME in the University of Abuja Teaching Hospital. The details are on this link. But the aim of this program is to establish programs to enhance the knowledge and skills of healthcare professionals to provide best practices, effective care, and self-management education for people with diabetes and their families. And the objectives are to promote high-quality education for health professionals in diabetes care, improve the overall quality of care, and improve the life of those at risk of or living with diabetes and their caregivers, to promote the access to and integration of healthcare professionals qualified in diabetes care, promote the essential role of diabetes education and multidisciplinary diabetes care teams to ministries of health, hospital authorities, and policymakers. Our students, we started this program in June this year, and our first set of students for this program are 18 in number, consisting of physicians. We have a dermatologist who is interested in wound care, who is part of the program. We have an ophthalmologist working on diabetes eye disease that is part of the program. We have pharmacists, nurses, and dietitians, reflecting the wide spectrum in the chain of diabetes care. So these are our staff. We have endocrinologists. We are lucky to have Dr. Abbas as one of our faculty members. So he's an adjunct lecturer to the University of Abuja. Dr. Abbas, I want to thank you for accepting to be part of this program. We have a lecturer from the education department who is, discussing education, methods of education, teaching methods, and all that. And then we have a psychiatrist, and we have psychologists. We have somebody from public health. We have exercise physiologists as part of our team. The dietitians are part of it. We have the pharmacists as part of the team. This program we started in collaboration with Diabetes Africa. and there was an MOU signed between Diabetes Africa and the University of Abuja. This is our Vice Chancellor. It was during the COVID time, so we signed this MOU virtually. That's the Vice Chancellor of the University of Abuja. That's my humble self, and some of the members of the team with the Vice Chancellor. And this program is taking place in a center that was magnanimously built by the former First Lady of Nigeria, Dr. Mrs. Aisha Buhari. So that center was built, and she graciously named it after my humble self. So this is the Diabetes and Endocrine Center in the University of Abuja Teaching Hospital. These are just excerpts from the commissioning, because she came to commission it herself. She's interested in diabetes and endocrine diseases, and that is what made her to do this. And so the program is a hybrid program. The lectures are all virtual, and then we have clinical placements. And what we did is to choose 4 teaching hospitals in Nigeria for convenience for the candidates. So we have University of Lagos Teaching Hospital, we have the University of Port Harcourt Teaching Hospital, we have Aminu Kano Teaching Hospital, and then we have University of Abuja Teaching Hospital. So depending on where is convenient for the candidates, they go there for the clinical experience. And the Vice Chancellor of the University of Abuja magnanimously employed professors of endocrinology in these institutions as adjunct lecturers to the University of Abuja. So in a nutshell, details of the program is in that link that I showed. So in a nutshell, this is what we are doing right now as far as diabetes education is concerned in the University of Abuja. Thank you very much.
Thank you very much, Professor. It was very nice and clear. It's really a very big milestone, and I'm very proud of it that University of Abuja took this initiative. We can now, it's open for all Africa. They have started for Nigeria, but basically all African students can go there and get a master's degree in diabetes. So that's well done job. We will have some questions in the end. I hope you will stay till end. It's an African program, Professor. And I will hand over now to my co-chair, Professor Maimuna, who will take the lead from now till we finish the program for 3 speakers. Yes, Professor, the platform is yours now.
Thank you, Dr. Abbas. I would like to thank again Professor Felicia and Professor Jill for their nice, beautiful talk. And I can see that there are already questions on the Q&A, and that they will stay, then we will discuss this hopefully. Now I would like to introduce the 3rd speaker, which is Helen Gifter Bitio. I hope I pronounced it well, Helen. Helen is an associate professor of medicine, consultant internist, and endocrinologist in Rwanda. And her topic is about wound bed preparation in patients with diabetes for low and middle income countries. Helen, the floor is yours.
Thank you so much, Maimuna. It's my pleasure to join you today for the food awareness campaign. Can you see my slides?
Yes, we can see it. Carry on.
Okay. So my topic says wound bed preparation in resource-limited settings. So this is a work in progress, and I will be presenting the concept of wound bed preparation. The wound bed preparation in resource-limited settings will be published in 2024. But the basic concepts are basically the same, so I will be discussing what wound bed prep is in general. So this will be my learning objectives, to review the components of wound bed prep and how to use the wound bed prep to optimize wound healing in chronic wounds, of which diabetic foot ulcers is one of them. And wound bed preparation is a paradigm that we use to optimize chronic wound treatment. And it's basically a holistic approach to examine into and treat the cause and consider patient-centered concerns, determine if a wound is healable, or maintenance wound, or non-healable, which we call palliative wound. So it's a paradigm and a kind of approach into treatment of wounds. It has 10 components and starts with identifying and treating the cause, patient and family-centered concerns, determining ability to heal. Number 4 would be what the local wound care should look like. And then number 5, debridement. So I'm going to go through them. Number 6 would be inflammation, local infection, moisture management, the healing trajectory of the wound, the age effect, and health systems or organizational support that we have as an institution to care for patients with wound. And if you are interested in reading further, you can refer to this article, which was published in 2021 in the Advances in Skin and Wound Care. So I'm going to start with a patient that we saw at the King Faisal Hospital in Kigali, a 58-year-old male who had diabetes for 18 years, hypertensive, developed end-stage renal disease, and went to India for kidney transplant, and actually developed a foot ulcer after the transplant surgery because he stayed on the side on his foot. So it started basically as a pressure ulcer because of the prolonged surgery that he had to do for the kidney transplant. So it started immediately after the kidney transplant. Unfortunately, the kidney transplant failed after he returned to Kigali, so he was requiring dialysis when we saw him after 5 months of having this wound on the foot. He had anemia, he was depressed, he was having loss of appetite, and in general, the total duration of the foot ulcer was 5 months. So as you can see on the picture, he has already lost 2 of his toe and part of the foot from previous surgery, which was done basically for toe gangrene when he presented with the initial ulcer and then symptoms of ischemia. His A1C was 10% and Doppler ultrasound showed peripheral arterial disease, more than 70% stenosis, and on audible handheld Doppler, we could hear monophasic waves, and X-ray showed osteomyelitis. So in this patient, so you can discuss on the chat box and go on with me. So what do you think are the causes that we have to identify and treat in this patient? You can write on the chat box what you think are the causes that are contributing to these non-healing or chronic wounds which have stayed for more than 5 months. So we basically define chronic wounds if a wound that didn't heal for 3 months or 12 weeks. So for causes, so I said he has diabetes for 18 years. So complications of diabetes in terms of peripheral neuropathy, peripheral arterial disease. Has uncontrolled diabetes, which is contributing to the non-healing wound. Anemia, malnutrition, infection, local inflammation. So immunosuppressive therapy, especially in the initial months, he had to take immunosuppressive therapy because he is post-transplant. That would also contribute to delayed wound healing. And the end-stage renal disease itself is a poor prognostic factor in patients with diabetic foot ulcer. So these are some of the things that I could list, but you can, if you have more causes that you can identify in this foot ulcer, you can put them in the chat box. When we look at the patient family-centered concerns, the first one is pain. So in diabetic patients with neuropathy, we may find that patients may not have pain because of the severe neuropathy, but some patients do have pain. So it could be a resting pain, and then it could be a neuropathic pain or nociceptive pain because of the infection, the inflammation. So it's a combination of pain, or pain could be because of dressing change, because of wound cleaning. So we have to grade pain and address pain. So address properly pain in patients' wounds. So we have to know the daily routine of our patients. So how do they walk? How much do they walk? How can we do offloading when they are walking? For example, for our patient, he was mostly bedridden, but he sure have to go to the restroom. So you have to plan for how to offload this foot, because as you know, the main self-treatment in diabetic foot ulcers is, we say, addressing the VIPs. Yeah. So addressing vascular, which is, do we have a good blood flow, which was addressed by Dr. Hardeep in detail. We have to address infection, and then we have to address pressure or offloading of the foot for a diabetic foot ulcer to heal. Habits, especially smoking, alcohol. So smoking especially is very important, because for a patient, for each smoke, if they have not stopped while they're having ulcer, it decreases the blood flow by at least 30% for the next 30 minutes. So for patients with diabetes, smoking is a no-no. But again, if a patient has a diabetic foot ulcer, then we have to do counseling, trying to help them stop smoking. We have to look into their support system in terms of how their family circle looks like, how their support is, how their financial mechanism is, or are they insured? Are they paying out of pocket? What they can afford in terms of offering them what kind of treatment we can do for them. Mental health is very important. So if you see in our patient, he's a patient who is going through a lot. So he's a patient with end-stage renal disease, with a failed transplant, who now has a diabetic foot for more than 5 months, who has undergone limited amputation, but still faces the risk of undergoing major amputation because of the non-healing wound and the critical ischemia that he is having. So our patient was already clinically depressed, so we have to involve psychologists to help us to discuss with the patient our treatment options. And then patient empowerment, because if we don't educate our patients and make them part of our decision making, then our treatment is incomplete. So patients should be making informed decisions in terms of what we offer for treatment and how they choose which treatment is good for them. Then the third component is determining ability to heal. So we basically classify wounds as healable, maintenance, and non-healable or palliative wounds. And the main factor contributing to whether a wound would heal or not is vascular. So as it was clearly discussed again earlier, vascular assessment is very important in a patient with diabetic foot ulcer or a wound, for us to decide, can we treat this wound? Would it heal? And also what kind of treatments we would offer for this patient. As I would come later, can we do a sharp debridement, or do we do conservative debridement, conservative surgical debridement, or do we do just autolytic dressings, or just we do palliative wound care? And we have to recognize also presence of uncorrectable causes in addition to critical ischemia in patients with chronic wounds. Then the other component would be the local wound care. So in local wound care, that would include how we cleanse the wound. So do we use potable water, saline? Do we use low toxicity antiseptics? How do we cleanse it? Do we soak it? Do we use irrigation? Or how do we debride in terms of, as I said earlier, sharp debridement? Sharp debridement is strictly for patients who have good blood flow. So in patients with ischemia, you have to use either a conservative surgical debridement or autolytic dressings or biologics, or sometimes you may use maggots to debride the wound. And then inflammation and local infection control is very important. Moisture management, again, moisture management is based on what kind of dressing you use in terms of, is your wound having excessive discharge, in which case you would use dressings that would absorb the discharge, or does your wound need moisture? So you would use dressings that donate moisture to the wound. So you choose your dressings based on what moisture balance you need in the wound for the wound to heal properly. And then you have to assess the healing trajectory. So if a wound does not decrease, the size of the wound does not decrease by at least 20 to 40% at 4 weeks, then it's most likely not going to heal by 12 weeks, meaning it's going to be a chronic wound if it goes beyond 3 months. So you have to know your wound information. So you have to document the size of the wound, the depth of the wound, by how much it's decreasing in size or increasing in size, in order to help you decide, is this going to heal, or do you need to reassess in terms of what are the causes and comorbidities which are contributing to the wound, the non-healing wound, as you expect it to be. And then we have the age effect, which is basically, can we use active treatment? So active treatment in the form of either skin grafts or biosynthetic grafts in terms of negative pressure, VAC treatment, or hyperbaric oxygen if you have it. So you would consider these active treatments again in non-healing wounds in which you think the patient have access to these treatments, and also if you have indications that this wound would benefit from active treatments, from adding active treatments. The 10s would be health systems that I will be discussing. So if you look at our patient's wound and then looking at the given history, you would think about, how do we do local wound care in this foot? What kind of debridement can we do? Can we do sharp surgical? So I said this patient has critical ischemia. So sharp debridement without a vascular intervention would be very difficult. So you need to have a vascular surgeon who will be assisting you opening up vessels so that you can do active treatment in these patients. In the absence of that, it will be difficult to do sharp debridement in this patient. Local infection and inflammation, then you would use investigations that would help you. So clinical science, of course, plus investigations that would help you to determine whether there is infection or not. In our patient, clearly there is osteomyelitis, but you can also look at the feet. Is there any discharge? Is it hot, tender, pain? Local science would tell you, is there any local infection or not? Then healing, friable tissue. This all would signify that there is local infection or systemic infection for that matter, and you need to decide whether to put the patients on antibiotic or not. And then treating the inflammation. So it's not only infection, but also controlling inflammation in wound healing. Then moisture management, definitely we would need this foot had a lot of discharge. So you have to use dressings which would absorb, take away the moisture, so that you would have a good moisture balance to help the wound healing. Healing trajectory. So this patient's wound was actually getting worse after 5 months of wound. So, and the main problem was vascular, but there were many contributing factors that were delaying the wound healing in this patient, that some of them are correctable, some of them were not correctable. And then in terms of edge effect, the surgeons did try doing VAC or negative pressure in this patient because it's a big wound, trying to bring it together, but it didn't work. We don't have access to hyperbaric oxygen. And later on, because the patient was not willing to undergo amputations, or he was not able to go for vascular surgery, they even tried skin graft, I know, after some time, which didn't also work in this patient because obviously his vasculature is compromised. So every wound comes with different issues. So it has different causes, or in terms of either neuropathy, ischemia, combined neuroischemic, or infection, site of the wound, comorbidities are different for each patient. So you have to go through these 10 components to help you figure out how you can help the patient to heal the wound. And in health systems, organizational support will be looking at, do we have adequate staffing? In terms of wound care is interprofessional. So you would need, let's say in a diabetic foot ulcer, an endocrinologist, diabetologist, you would need a wound care nurse, you would need a podiatrist or orthotist, you would need a vascular surgeon, you would need a psychologist, and more in terms of team that are working together in the wound care team. Do you have evidence-informed protocols in your institution for diabetic foot ulcers? Do you have interprofessional team culture? So do you see your patients together, or do you refer to each other patients, and patients are going to different units for consultation, or are you doing consultations together and the patient is at the center? Availability of diagnostic and treatment options in terms of it could be laboratory diagnostics, let's say in diagnosing infection. Do you have culture facilities that would guide antibiotic choices, or do you have facilities to investigate for, let's say, vascular? Can you do CT angio to diagnose and help you guide do vascular interventions in your patients? Or treatment options, let's say offloading options for your patients. Do you have orthopedic orthotics, podiatrists, which are helping you in offloading of your diabetic foot ulcer patients? What can your patients afford? Do you have patient insurance scheme? Are patients paying out of pocket? How much can they afford? And then you have quality improvement projects, which are looking into what are your challenges, what are your outcomes, and how can you improve outcomes by getting feedback or audit from what you are doing in your institution for patients with diabetic foot ulcers. So these are things that we have to consider in health system organizational support in the wound bed prep paradigm. So I'm going to finish with the World Diabetes Day theme for this year, which is know your risk, know your response, because diabetic foot ulcer prevention starts with preventing type 2 diabetes, diagnosing early type 2 diabetes and controlling it, and of course educating patients on how to prevent complications, including diabetic foot ulcers. So know your risk, know your responses in terms of lifestyle modifications, get screened, advise your colleagues, families, communities to get screened for type 2 diabetes. Thank you.
Thank you, Helen. Thank you, Very nice talk, and you're absolutely right. You need to know how to do this wound bed preparation. You need the knowledge, but you also need the health system and the organizational support to do it. So thank you very much. There will be certainly many questions at the end. I would like to suggest that for time saving, that we move on to the next speaker. The next speaker is Dr. Chidi Mbonani from South Africa. Chidi Mbonani is a qualified podiatrist with over 13 years of experience. She currently works in the public sector as well in private sector, where she focuses on saving lives through saving limbs. Her interest in diabetic foot care and early childhood intervention has also given her a platform to teach on early detection and management of diabetic foot complications with a positive long-term outcome. She has also shared her knowledge and experience in different countries, South Africa, Kenya, Denmark, Spain, and USA, to name a few, as well as in her own country, South Africa. She has served as the wound care committee at Chris Hani Baragwanath Hospital, where she also served on an advisory board. She has and still is involved in continuing education of podiatrists and other professions in wound care and current trends in diabetic foot management. So her topic is about the challenges in the management of diabetic foot complications. And I would like to give you the floor, Mrs. Chidi. The floor is yours.
Thank you so much, Professor.
Can you hear us?
Yes, I can hear you. Can you hear me?
Yes, we can. It's clear.
Okay, great stuff. Good evening, colleagues. My topic for today, we're looking at the challenges in the management of the diabetic foot complications. And I think Professor Felicia did such a wonderful job in terms of allowing us to understand better regarding diabetes and also to understand the disease burden and the stats that are out there. And I'm trying to move, but it's not moving. Okay, there you go.
Can someone from the IT help? You are still on the first.
There you go. Now it's moving. And it is quite important what Professor Felicia was talking about regarding diabetes worldwide, but more so in Africa. And it is obviously increasing with time, and the disease burden actually plays it's a contributing factor when we're looking at the challenges that we face as podiatrists in the management of diabetic foot complications. I looked comparatively with our closest neighbors, and that is Lesotho, Botswana, and Zimbabwe. And if you were to look at it, South Africa, it's at the prevalence of about 11.3%, and it's far more than our neighboring countries that are close to us. It is quite concerning as well, because the disease burden will proliferate what we call the complications that come with it. But more so, what we have actually been released in South Africa, Stats SA also released that the disease burden in South Africa has grown by a percentage of 53. How the system works is with levels of care. And I know that as the speakers were talking, they were talking about the levels of care. The mission of any national health department, including South Africa, is to improve health status. And this is through prevention of illness, promotion, which is healthy lifestyle, and also improve what we call healthcare delivery. But healthcare delivery can only be achieved by access, equity, efficiency, and quality, but more so sustainability. If we look at how the levels of care function, they're interlinked, and they're interlinked where we need to also have the implementation of health delivery platforms. And these health delivery platforms will obviously assist us with improving quality of care and therefore improving
excuse me.
quality health outcomes.
Tishit, your slides are not moving. Are you moving it yourself?
I am moving the slide.
On your screen, it's moving?
Yes, it is.
Yeah, in our screen, it's not moving. So I don't know whether it has been shared properly or not. We cannot
It seems to have
see you moving.
paused. Let me stop it and reshare it, Prof.
Yeah. Yeah, we can now see levels of care. Okay.
Okay, all right. I will not return back to the other slides. I will just continue from where I am.
Okay.
As I was saying, talking about the levels of care, it is a brilliant structure, and it leads to be implemented in terms of from the health delivery platform perspective, and it also looks at giving services where there's quality care that improves quality of life, but also health outcomes. The hierarchical relationship between the levels of care is ideal, and in an ideal world, it has to be synergistic. And this comes in where there's early detection, early identification, but also including early intervention of such cases. However, because of the differences in areas, but also the accessibility of podiatry services and certain healthcare services, we find that certain patients do not get access to all healthcare services that are rendered. This is an integrated referral system that will help in receiving the patient, where the patient can receive the necessary treatment and get the treatment in time and as they require. And this will prevent from this will prevent complications presenting, but also it will prevent amputations. So there are many challenges that we need to consider when we look at diabetic foot complication management. And there's a myriad of these challenges, and they are not unique, and they come in different forms and shapes. However, I looked at what I would consider the top 6, and the first 2 are interlinked because we're looking at the disease burden, but also looking at the low numbers of podiatrists within the local clinics, but also within the public sector. And as I said, I believe that South Africa might be a little bit on the advantage in terms of they do have podiatrists. However, if we're to consider some countries in Africa, they do not have podiatry. Therefore, some of these patients are missed within the cracks based on the not accessibility of podiatry. According to literature, from a study that is done, and what I'm presenting currently is raw data of what was done at Chris Hani Baragwanath with my colleagues, where we looked at year-on-year increase in disease burden. And this disease burden will obviously, when we put it juxtapose the complications, we see with an increase in disease burden, there is an increase in the complications. And in the third slide there, where we putting diabetics with the complications, you can see the increase in the diabetics, but also in the wounds that presents. And in another study that was done, it was indicated that with an increase in disease burden and therefore resulting in an increase in complications, there will be an increase in amputations. And currently, these amputations precede infection. Patients present late at clinics. There isn't any proper initial intervention in terms of foot care. In a study that our colleagues from University of Johannesburg did, they looked at the prevalence of diabetes, but also food complications. But more so, they looked at limb amputations, and these limb amputations come at a price. They looked at just over 1,800 patients and only used about 1,500 of those. And those patients were looked at from a perspective of, one, we need to consider that most of these amputations, they precede infection, and it was about 84% of those patients that actually did have the amputations done. And in the study, 73% of the patients that have had amputations, they were actually major amputations. And all the speakers mentioned one or two things that are a contributing factor from a clinical perspective, be it peripheral arterial disease, be it peripheral neuropathy, and also just basic life support for the patient, and also an understanding. One of the biggest challenge that we face as professionals is the interprofessional and the multi-professional and interdisciplinary team care, where we're looking at the patient and giving patient-centered care. The person in the circle, where we understand that their concerns need to be addressed first, and as professionals, we play a role in improving their quality of life through our expertise as different professionals. We also look at how can we use what is accessible to the patient so that they can benefit from the knowledge they get from us. Professor Felicia spoke about education and knowledge. Patients who, as a profession, and we are interprofessional, we work together, not working in silo, that get education from the professionals, a better place to adhere to treatment, better place to adhere to knowledge, but also because they're involved, they're better placed to take charge of their condition. We ought to remember that patient-centered care looks at also the scope, it looks at also our ability to focus on the responsibility that we hold as professionals. But also we need to look at healthcare professionals caring for the patient. And if we work in silos, we are unable to reach a consensus in terms of how and what do we implement to allow the patient to gain from this, and also to either prevent amputations, to save a limb, or to assist in the facilitation of wound healing. Another challenge that is common in Africa is accessibility. And if we were to look at rural Africa, they have a challenge of not getting as much services where they are. Accessibility, we're looking also at the distance, because patients might feel despondent to travel long, therefore they don't get access to the services that are available to them. We also have clinics that are further away from where the rurals are, and that also plays a very big role in a lot of disparities that we get due to diabetic foot complications. Barriers that we also see in terms of accessibility is that transportation, the cost of either transporting or the cost of buying whatever that is necessary. Accessibility is not only limited to the patients, it's also limited to the healthcare professionals. You find that healthcare professionals are in a facility, but they do not have what they require to be effective in what service they want to render. And also we need to look at what is it about rural communities and accessibility that prevents them to be able to receive the services that they need, because patient decisions also play a role. We have a need for us to understand that the workforce issues also play a role. And if you can see on the top picture there, we have in percentages the differences of what are the contributing factors in the rural communities that actually affect accessibility. In a study that was done in Venda, it looked at the dimensions of access, and this picture or this table was taken from that research, and this is in the experience then and the challenges that we're experiencing now. There isn't really any difference because of they seem to be similar. Location, supply, and demand, where you have an increased number of people requiring the services. However, you have your human resources is lacking. Financial and incidental cost as well. A lot of people would require to travel long distances to either the cities to get treatment, to get the necessary services they would require. Another thing is awareness and literacy. And it is important because of the primary healthcare service, its aim is to educate and to empower through knowledge so that patients can fully understand in terms of the prevention of type 2 diabetes or the management of type 2 diabetes, and also the prevention of diabetic foot complications that may present. If we're to look at this slide now, it's similar to what was presented before, but we need to look at the socioeconomics as well. The cultural factors also play a very big key. We have patients who still today, they would think they don't have diabetes. However, they have, they've been bewitched, or it's the ancestors saying something to them. So there is a cultural aspect to certain belief systems. There is a cultural aspect to certain decisions that patients make. And more often than not, we do find patients that would come and say, I was sent to a traditional healer. My family felt I did not get proper services from the clinic. Therefore, they took me to a certain place. And this requires us to be patient in educating and making patients aware of what is needed, what is required, but also how this can also play, contribute to having a complication. We're looking at language and communication, cultural and societal issues. In cultural and societal issues, we're looking at a stigma. I was chatting to Professor Hadib earlier, and I was saying to him, I had to have a very difficult conversation with a very young lady, 38-year-old, and she was about to go to have an amputation done. And the decision was they were going to do a baloney amputation. From a cultural perspective, she was now worried about how the society is going to see her, how now she's going to live a life without a foot. And it was a difficult conversation because you had to have a paradigm shift in terms of the mindset and the thinking, but also looking at how do we save a person's life without with them understanding why they need to have an amputation done. Patient adherence and its roadblocks. We have moved away from patient compliance because patient compliance simply means a patient is being instructed as to what they need. Compliance looks at it's a command and order that needs to be obeyed. However, when we look at patient adherence, and this is what recent literature is emphasizing, is that there is the ability of a patient to follow through on treatment, is the ability of a patient to be able to be involved in the decision making. It's the ability for a patient to understand the process of the treatment, but also be part of the treatment and not be a standby. And this is where patient-centered care plays a role, because we are addressing the patient's concerns. We are also listening to a patient's perspective, but we are collaborating with the patient, and not just the patient, but the supporting structure of the patient. And we need to get to a point where we move to what we call coherence. And coherence is where you have a frank discussion with a patient based on the ability to adhere, and you're able to make decisions that will benefit the patient. And we're looking at risk and benefit in this instance. However, we're also looking at perhaps we're also looking at what is it that the patient understands about what the decision that has been made. And we're looking at the 6 at the moment of the roadblocks of adherence. Number 1 is knowledge and health literacy. If a person doesn't understand, if a person hasn't been given knowledge to empower them, they will not find the need or see the need to adhere. Negative belief systems also play a role in terms of stopping or being a roadblock and contributing in patients not adhering, because there is a negative belief that I cannot die and be buried without my toe or without my foot. If now I'm amputated, does it mean I'm just a disabled person? And this is where the multidisciplinary team needs to add, a social worker needs to add a psychologist, where of the patient needs to be addressed, where a patient needs to be seen not just a form of treatment, but also in a holistic manner. We see a patient as a whole and not just the hole on the foot. Dissatisfaction with treatment. There are many instances where patients believe what they believe and they will be dissatisfied with the services they've received, even if the service benefits them. It is our duty, but it is also our responsibility to teach. Whenever you have a family member, whenever you have a carer, or you have any other support system, it's important to teach both so that they both understand. And I find that dissatisfaction with treatment seems to shrivel away once one has educated properly and has shared the knowledge with the patient and they understand what the process is. Cost is also one of the roadblocks. More often than not, you'll find a patient saying, I cannot attend your clinic because I do not have money to come to the facility, or the facility is too far, or I cannot even drink medication because I don't have food at home, and my glucose levels are not controlled because the only thing I get access to is just porridge. And there's so many factors that are cost related that may play a role and may be a roadblock in patients' adherence. And more often than not, we need to tap into that way. Our assessment also goes beyond so that we can identify other socioeconomic challenges. So they need to go beyond just looking at the patient's foot and understanding what the complications are and managing them, but also what are the factors that can affect the process of healing, but also that can be a roadblock towards the patient and also prevent the patient from adhering. Convenience and effort. Patients tend to come where life becomes convenient for them. If they come to a clinic and they feel they are treated with respect, it's convenient for them to go there. If it's closer, it's convenient for them to go there. If they get the services they feel they are satisfied with, they will obviously go there. And this will allow them to have effort. However, if it's not convenient enough for them to come, they do not make an effort. They would not want to be involved. And remembering that depression and diabetes are also very much interlinked. And because of that link, we need to consider the fact that that could also be a contributor in part of being the roadblocks. Memory is also one of the other roadblocks where patients quickly forget. And if they forget and if they don't remember, they might not do what is required of them. And it's a matter of how do we encourage remembrance, write it down, give them a pamphlet, draw something for them, or allow them to take it upon themselves to write the dates for their appointments as well. We find that some patients complicate because they do not come to their appointments, and it is a challenge because the follow-up doesn't happen as and when it should. Therefore, the patient doesn't get the required management and treatment they need. So Professor Felicia and I were we were thinking the same way. This is one of my favorite quotes, where if you tell me, I forget. If you teach me, I may remember, and may being the operative word, but if you involve me, I will learn. And we need to be able to involve the patient, to involve the patient support structure, to involve everyone that is surrounding the patient. That includes us as healthcare professionals, from a learning perspective as well, from us, from a supporting perspective, where we can obviously depend on each other as healthcare professionals to reach a positive outcome for the patient, but also making a decision that will benefit the patient as opposed to put their lives in danger. So if we want to move from a complication whether it has presented late, or a complication that has been post-surgical, or complication that has presented due to other complications from peripheral neuropathy or arterial peripheral arterial disease, we need to be able to identify the loopholes, but also the challenges that may present. Once these challenges are identified and are dealt with and are also addressed, we will find that patients adhere better. We address all the challenges that we may come across, and in most cases they may present all at once, and in some cases they might present one and not with the other. However, we need to have the wisdom, but also the knowledge and the tact in identifying these challenges. In conclusion, and as part of our take home, is that the health system is structured, and is structured in an ideal world. The structure does work. However, the structure needs us, as well as clinical people and healthcare professionals, to work with the system to make sure that it follows through. Structured patient assessment is also key, be it using the primary healthcare as effective as possible, and allowing patients that need to be seen either at a quaternary level or a tertiary level to be addressed there. This allows for basic education to happen at primary healthcare, but also for very serious complications to be addressed at a higher level. And this synergy between the levels of care assists us in obviously making sure that the patient receives the treatment they require. Improving patient care at primary health care is very key. Patient-centered care, I cannot stress it enough. It is important that we consider we are not treating the whole on the patient, but we're treating the whole patient. A patient might be a breadwinner, a patient might be a parent, there might be someone's child, etc., etc. However, we need to consider that we are not just treating the whole on the patient, we're treating a patient and a person who is interlinked to other people, and we're dealing with human beings. And if the emotional aspect of things are not addressed, then we will have a ripple effect of other things happening. Making efforts of rendering affordable food care service, but also making an effort of sufficient and sustainable food healthcare services is key and important. This allows us to play a role in the prevention of amputations. It allows us to work together as a team with other healthcare professionals in limb salvage, but more so in the prevention, because prevention is better than cure. Collaborative work is important. Collaborative work is what would make the management of diabetic foot complications a little bit easier, but also it will allow us to work not in silos, but as a team where we are able to share our expertise within the boundaries of our scope, but also we are able to assist the patient as best as we can. We improve quality of life through the improvement of the services that we render. With all that said, thank you very much.
Thank you, Mrs. Chidi. Thank you very much for putting up all those challenges. You showed us the challenges linked to the healthcare system and those related to patients themselves. And I can assure you that we all learned by just listening to you. We learned from you, we learned from Felicia, from Hardy, from Helen, and I'm sure we will go on learning with the last but not least speaker that I would like to introduce now. Our last speaker is Dr. Charlie Lumede Ilenga Bongo. Dr. Charlie is endocrinologist at the Department of the Faculty of Health Sciences at the University Marian Gouabi, Brazzaville, Congo. Dr. Charlie will give us an overview of diabetic foot in 2023 in the Republic of Congo. Dr. Charlie, the floor is yours.
Thank you very much, dear mentors, Professor Maimuna and Professor Habas. It has been a long time we know each other through this long journey of diabetic foot in Africa. And it's a great pleasure to be with you because it's my second time to participate at this African Awareness Week in diabetic foot. Thank you very much. I'm gonna share my, I think it's this one, my slides. Can you see there?
Not yet.
Not yet. Yeah, okay. You can see, right?
And for the participants, you can go on posting your questions, and right after Charlie's talk, we'll discuss.
So you can see now my slide, right?
Yes, okay. So go ahead.
Yeah, thank you very much. So I was proposed to talk about diabetic foot, an overview in 2003 in Congo, and this is my agenda. So this is well known that diabetic foot is the major public health problem, and these complications it will occur in 15% of people living with diabetes. It's the cause of long duration of hospitalizations, and also the financial cost of management of diabetic foot in Africa is difficult to estimate. And it's linked with high risk of amputation, and we know that it causes almost 80% of non-traumatic amputation every 20 seconds. And the cause of diabetic foot are well known, so we can prevent it in 80% of cases. And in Congo, we have the studies that give the prevalence of diabetes in Brazzaville 7%, and diabetes foot is almost 15% in Brazzaville. Here in Point now where I work, it's almost 8.5. That was 2018, and I will give you the new figures now for 2023. So we screened peripheral vascular disease in with diabetic foot ulcer. In patients with diabetic foot ulcer, it was 42% that it was with the screening of ankle brachial index. And the neuropathy in Congo, it was about 84% in diabetic foot patients. So how is the management of diabetes organized in my country? Actually, we know that at the institutional level, at the Ministry of Health, we have a program of non-communicable disease, but this program it doesn't have any specificity in diabetic foot. And we have now almost or more than 15 endocrinologists in the country, in the two main cities of the Congo, in 6 hospitals. In my hospital, I have 15 beds. Sometimes I have 50% of these beds are occupied because of diabetic foot. So we have also active associative initiatives which help with trainings, with partnerships and advocacy and awareness in any area of diabetes, and specifically with diabetic foot. The association centers in Brazzaville have launched many diabetes activities, and also it was involved in the DAFI program. So we've been talking about resources. I think Professor from Nigeria talked about it, and from South Africa also. So what we have actually, or which kind of resources we have in my country actually available. It depends on the components of the diabetic foot patient admitted in the unit. We have actually the dietitian, psychologist, and diabetologist, cardiologist, nephrologist, and also microbiologist and infectiologist. We have surgeons, but we don't have these vascular surgeons. We have vascular surgeons, but they are limited with the technical platform is very, very limited. And we don't have angiologists available actually in the hospitals. So with the specialists, we have also we can do X-ray and MRI or culture with antibiograms. And we cannot do angiography and TCPO2 or MRI angio and everything. And scintigraphy is not available in the country actually. So the main challenges we've been facing from the long journey I have passed through more than 10 years already, was the trainings. When we are training through different conferences and workshops and webinars also. These trainings were aimed we aim to align ourselves in the international standards and recommendations in diagnosis and treatment. So we went through many trainings, starting with step-by-step program in 2009 in Kinshasa with Professor Abbas, and we finished with Professor Maimuna and the food training in Marrakesh in 2018. And many programs concerning education of patients, specifically with diabetes foods. Also, our nurses were trained during some international congresses in Addis Ababa and in Brazzaville, and also we have a partnership with Professor Maimuna in these French-speaking, words, because they have a good experience. And we sent there in Dakar 2 nurses who were trained specifically for wound management in my service. So in Pointe-Noire, actually, I'm the only one diabetologist in my hospital. We are 3 in Pointe-Noire, but in my hospital where I work, I'm the only one. I have 2 nurses trained. We have 2 orthopedic surgeons, and we have an infectious disease specialist who are not too much involved in management of diabetes food, why it should be. And we have psychologists also usually come to my service. We don't have vascular surgeons or podiatrics or shoemakers and like other people or other countries they have. So these are the faculty members we met in Marrakesh, and this is the workshop we went to. So what are the results in my country, or specifically in Pointe-Noire? For the last 23 years in Pointe-Noire, we in my service we received 311 patients. And 44 of them were with diabetic food. So it's like 14% of people admitted in my service were admitted for diabetic food. This like the same prevalence published by Monabeka and collaborators in Brazzaville. It was about 15%. So most of them are men, and the mean age was 57, with mean duration of diabetes 9 years, and the mean duration of hospitalization was 26 days, almost 1 month. And 93 of them, they were known with diabetes. While they were admitted, 30% of them were admitted with interruption of treatment, and 91, of course, were type 2 diabetes patients. So as you can see, this incident per month, we can see that we have more patients during the month of August, June, and July, and September during the last 23 years in Pointe-Noire. And if you want to see or to compare with the last month, you can see in this month, we've seen people admitted with 70% of these people were admitted with classification SYMBAD from 5 to 6. So this explains that they are almost admitted late. And the duration of the main duration of hospitalization, I said it was 1 month, starting from 2 to 80 days. And what we noticed this year is the decrease of the amputation rate. Maybe this with a small bias, because some of the patients are not directly admitted to my service, they go straight to surgery. But concerning the patient admitted to my service, we've seen that we decreased the law of amputation, even though we've seen that some of them, of course, they refused to be amputated when it wasn't indicated. But the mortality rate is still high, very high, almost 20%. But when we compare with the last year, it's a decrease of 5% in my city. And we can see the microbiology, it's almost the same. We see many gram-negative microbes, and then the one we describe empirically, we can see gram-positive, but we see most gram-negative. And the thing is, we still use swabs for culture, so maybe it can bring some bias. We don't use biopsy, tissue biopsy or bone biopsy. So this is still poor diagnosis if we can criticize this. As concerning the peripheral artery disease, we still diagnose with this. We still diagnose this condition clinically with passed palpations, or in out of 100% of our patients, only 22% underwent vascular Doppler ultrasound. So it is poor diagnostic still. It doesn't help us to diagnose properly the conditions in our patients here. And of course, you see, when we go through swabs, if we want to diagnose with microbiology, we have only 80% patient who can go to pay for this analysis in the laboratory. This we got a donation not a long time ago. Actually, now we can use the Doppler to screen an anchor brachial index in my service. So I can see now if this is the gold standard of diagnostic of peripheral arterial disease, we can now properly diagnose it very soon. I think we'll be giving you new data for the next years coming. As you can see here, we are screening anchor brachial index in our patient. So, as concerning treatment, we use when the patient are admitted, we use broad spectrum antibiotic therapy, covering gram-positive and gram-negative anaerobes when they come with infection. Most of the time, they come with the infected food, and then we go with the swabs and the culture. As I said, we don't have actually possibility to use tissue or bone biopsies. So we identify microbes, and then we can fix the treatment with the result from the labs. And usually we can see that the results from the labs brings us is like imipenem is almost sensitive and amikacin. This is the type of infected food we see, and 55 or 80% of them are infected, as you can see. And this, some of them admitted and treated till the healing, as you can see. This now is a peripheral arterial disease, and this foods, most of this food we see, they finish with amputation, whether it's amputation of tools or the limb amputation. And this peripheral arterial disease we can see in 20 to 23% in our patients, actually. And because we don't have a vascular surgeon, when we don't have revascularization, these patients, all of them, most of them, 100% are amputated. So then we focus on the prevention, because we know that prevention is the cornerstone of amputation in diabetic foot. So we went through the education of healthcare professionals, and we take time to examine carefully patients, especially during the consultation, starting by identifying minor signs of infection or identifying neuropathy and peripheral vascular disease. And also we go through the gradation of risk, as you can see here in this foot with colors in the photo. So then we establish the follow-up of patients, and also of the patient and their family members. They go through education session with using the MAP conversation with the specific items in diabetic foot. Also, we teach them how to choose the best shoes, the best socks, and how to cut the nails, how to identify the minor signs of diabetic foot, because we know that it starts by the small or minor signs and finish by amputations. Sorry. Something goes wrong with my windows. Okay. We go through the media also to educate people with diabetic foot to prevent diabetic foot by the small session with the media. So we still have to face with against the weaknesses we have, and we still have to face this to prevent, because we still don't have evidence-based international recommendation, not always accepted in the hospital. I mean, to work together as a team with the colleagues from surgery, the surgery services. We have lack of specific program at the Ministry of Health, and lack of awareness, and we're trying to join the initiative now brought by the DFoot International. But this, I shared, for example, the poster, but the people, they were all of them, all of the time claiming that we don't understand English, so we cannot go through this program. And lack of actors and collaboration between us, podiatrics, educators of diabetic foot, and technical platform is still insufficient. Like we have surgeons, we have professors in vascular surgery, but they don't do revascularization in Congo. And we still have, of course, to fight against myth and traditional practices, traditional healers and pastors in India. And as we've seen, we have to fight again to delay before admissions, because you've seen that 70% of our patients are admitted with CMBAT 5 or 6. So we'll go through education and fight against this weaknesses we see in my country till now. So in conclusion, we can say that the diabetic foot in Congo in 2023 is still frequent, and we can see that foot care management still need multidisciplinary partnership. And I lost my screen, I don't know why. Sorry. So we still have to fight and to educate and to bring many international evidences and recommendations through our collaborations in the teams, for people to understand that we can do many things together to limit the amputation and to prevent diabetic foot in my country. And we still have many challenges for next year coming. Thank you very much.
Thank you very much, Charlie. The challenges you mentioned are shared by many of our countries, and you have to be encouraged, because you're doing a lot out of almost nothing, which is very remarkable. And this highlights for us the need to maintain our efforts for prevention, through awareness raising, through education, as Professor Felicia mentioned, through building our health systems. Dr. Helen mentioned it, and stop working on silos, Mrs. Chidi said. And when PAD arises, we need to build our health systems to be able to take care of it. Thank you very much, all of you. I'm handing over to to the president, to our president Abbas, for the Q&A session. Thank you.
Thank you very much. Thank you, all the speakers. Thank you, Maimuna. Thank you very much. Okay, we have really run off of time, but we'll have some discussion because people are waiting to answer a few of the questions. Professor Felicia has just joined us again, and there was a question for her. There are participants who's asking, they're very much interested in joining this course from outside Nigeria. So, Professor Felicia, as I'm very much impressed and really you have done a great job, can you let us know how to go about, and all people in Africa and globally are listening to you. Welcome, Felicia.
Thank you very much. Thank you. Sorry, the internet had some little hitches, so I was off for a while. Well, it's a hybrid program. All the lectures are virtual. And then that's first two, it's a 3-semester program. So the first 2 semesters, the lectures are virtual, but the 3rd semester is clinical placement plus, a master's thesis. Now, from East Africa, I will want Dr. Abbas, who is one of our adjunct lecturers, to consider having a center for the clinical placements in East Africa. I will want him to look at that. He's already part of us. He knows the program very well, and he's very happy with the program. And I think it's something you can consider, Dr. Abbas, and the discussion can continue on how we can involve many more African countries. Thank you very much.
Thank you very much, Felicia. Thank you. I would suggest that I agree with you, there's no problem on that. But if you can just send me some more details, we can put it in next newsletter, because I told you this course of University of Abuja will be there till I finish my term. So that be assured. It's for Africa, and we have to do it for Africa. So just send me the links and what you showed me. You are welcome. You show the links and everything, so people can go there and how much you have to pay and all these details. And I assure you, all 8 newsletters will have this. Okay, thank you very much. Thank you. Yes, Professor Shakawi is there, and he wants to ask questions to Dr. Jill, because you are in the same team, same professor. So there you are. Floor to you, Dr. Shakawi. You can, Professor Shakawi, you can ask.
You are welcome. Thank you very much, Mr. President. I'm very thankful to the wonderful board in this region, although I'm also African, but I'm in another region. I don't know why. The lectures are wonderful, really, very nice, very informative. I just want to stress points in my specialty. Number one, when the physician sees diabetic foot, he have to put in mind that the vascular part of etiology is 25%. So 1 each 4 of them have vascular problem, whether arterial, venous, or lymphatic. This is number one, because there are 5 major etiological factors they have to know. And for example, the blood quality factor is 85%. And the combined factors are 90%. And so we have to cooperate together not to lose the limb. If a vascular surgeon alone treats the limb, he will lose it 100%, because the etiology is usually combined. This is number one. Number two, the disease in the diabetic foot lesion in the arteries are usually infrapopliteal, less up, and it's characterized to be beaded, so that we can diagnose that he is diabetic from the radiological morphology, beaded vessels, like the beads. Also, when we find diabetic have infrapopliteal arterial disease, take care that the coronaries is 75% affected because it's the same size, the popliteal, the trifurcation, and the coronaries. The last point is, please, after revascularization and being successful and happy, don't leave the patient, because the minor infection in the foot will be measured in hours, and the patient will be in septicemia and go to the ICU, and you will do amputation for the patient with pedal pulses just to save his life. So when you finish revascularization in diabetic foot patient with minimal infection, it will kill the patient if you didn't do debridement immediately after revascularization. These are the major points. As regards the course of Abuji, it's very nice, but I didn't observe that there is vascular surgeon over there. Is there? There is no. We are only endocrinologists and other nutritionists and something like that, and no vascular surgeon. Usually in our country, we are vascular surgeon, we are taking care. We were doing bad with the internist, and we are surgeons, we do everything. Then we realized that they are very important. They are more important than the surgeon himself. They prepared everything. They can do post-operative care. They can save the patient life. Thank you very much.
Thank you, Professor Shawkawi. Professor Shawkawi is from Egypt, Cairo. So he's a vascular surgeon. Anyhow, there's another question to Shirip that you mentioned about inter and multidiscipline approach. So can you just brief, there's a question there.
Thank you, Prof. It's actually a very good question because of the conversation being, do we need to be next to each other for us to work together? However, if I'm inclined more to believe it's not about importance, which one is important, which one is not. However, which one is effective in the facility in the area that you are at. We're looking at interdisciplinary, we're looking at synergy, we're working together collaboratively towards the same goal. And the same goal has to do with the expertise and the science where it's in one integrated plan. So we find that when we are interdependently working with each other, it's easier, but it's also more effective that we understand what the other is doing and we're integrated in our plan. When we're looking at multi, it's more separately working and working in parallel, and not necessarily looking at how can I make sure that, how can I assist in making certain that a patient benefits from both my counterpart and they also benefit from my clinical expertise. So I'm more inclined to go for the inter as opposed to the multi, simply because of multi also might draw a line as if it's more in silos as opposed to working together towards a common goal.
Thank you very much. It's very clear. Dr. Gill, I think you had the highest number of questions, almost reaching to 10, and you have replied to all of them. But the last one, it has come here. Are all the vascular techniques of revascularization available in Kenya? That also I want to ask. And how should we go about? Should we go to India or South Africa, or should we come to you?
Okay, thank you very much for that question. So in terms of endovascular strategies, so plain balloons, which are not drug-coated, then drug-coated balloons, plain stents are all available. We have a few covered stents, but we don't use them that often. Drug-coated stents are not available, drug-eluting stents. But majority of our endovascular work is done with plain balloons and drug-coated balloons. In terms of stents, bare metal stents are readily available. Covered stents occasionally available. In terms of open surgical procedures, okay, fine. If you don't have a good vein, then PTFE grafts and Dacron grafts are available. So we can do majority of the cases. The only thing we don't have are atherectomy devices, like the Rotarex atherectomy device that I mentioned is not available, but it's not Train Smash not having it. Majority of the devices are available. We do 90% of our work with plain balloons and drug-coated balloons and plain bare metal stents.
Okay, thank you very much. The time of interest. Helen, there is one question to you regarding somebody asked, putting any special dressing for diabetes patient on a wound preparation. Are you there, Helen?
Yes, Abbas. I'm
Yeah.
here. Yeah. So there is nothing special in terms of choosing wound dressings for diabetic foot ulcers. We choose dressings based on is there infection, so infected versus non-infected wound. So because in infected wounds, you would choose, let's say, silver impregnated dressings because they have antibacterial activity, or hydrogels or iodine impregnated dressings that would help you with fighting the local infection. And also, as I said, it depends on the moisture balance of the wound. So do you have too much discharge, dry wound, or normal moisture wound? So I wouldn't say there is special dressing for diabetic foot wounds, although some say hydrogel dressings are better for diabetic foot ulcers than other dressing types. But whatever dressing you have, so for most of our settings, we don't even have the foam dressing or hydrogels that I'm mentioning. So sometimes we just use gauze, sterile gauze, maybe saline soaked or with iodine, or sometimes with Vaseline. So whatever dressing that you have to do it based on what is your wound type in terms of moisture balance and presence or absence of infection, local infection.
Okay, thank you very much. I think it's a time we have to close up, and I would finish it up by saying I would like to thank all the speakers, Professor Felicia, Dr. Gill, Helen, Trishit, and Charlie, all of them who took the time for their busy schedule and accepted invitation to talk and be part of this program, this important issue. Thank you very much indeed. I would like to thank my co-chair. She's always there to support me whenever I ask her. Memuna, thank you very much for supporting me, and I hope you will carry on till I be a part. I would like to thank all the board members and regional chairs and advisory for DFoot International for working hard to get this program in 7 regions. And we have one of the regional advisory here from MENA region. Thank you very much, Professor Shawkawi, to join us. Really, we feel proud that you became a part of Africa. Thank you. Special thanks to the core team of Diabetes Food Awareness Program, Secretariat, and IT Service. Thank you very much. And finally, I should like to thank all the delegates, because without delegates, no webinars are possible. So a very big thank from my left ventricle. Thank you very much. And thank you very much for being part of it. Hopefully, we will see you at least to see you on 12th of November, which is Sunday, for a global meet. And you can always attend other sessions, but please be there for a global meet. We have 2 renowned speakers who had received Lifetime Achievement Award in May in one of the biggest Hague food conference. So once again, thank you very much, and I won't keep you much. Thank you very much.
Thank you.
Thank you very much, Dr. Abbas. Thank you, colleagues. See you.
See you.
Thank you.
A good night.